So if we can begin the webinar by acknowledging the traditional owners on the lands on which we gather and pay our respects to their elders past, present and emerging. My name is Liam Caffrey and I'm the facilitator for this evening's webinar. So the overview of the webinar today is that we're very honoured to have Professor Arun Aggarwal, who will do a presentation. And we have a number of panellists that are with us tonight. So that's Eric O'Honan, Peter Goff and Kathy Netherwood. So after Arun's presentation, we'll be having a facilitated discussion. We'd welcome questions from the audience. And the audience can either put their question in the Q&A or the chat function of the Zoom. So that's a floating menu at the bottom that you can see Q&A or chat and that you can type there. We'll monitor that during the presentation and during the facilitated discussion. And if we have time, we will certainly ask the panelists or our presenter, Arun, the questions that you raised there. Like I say, we're very honoured today to have Professor Arun Aggarwal. Arun is a highly experienced neurologist with expertise in chronic pain management. Professor Aggarwal graduated from the University of Adelaide in 1987 and went on to specialise in neurology, rehabilitation medicine and pain medicine, and is a fellow of the Royal Australasian College of Physicians, the Australasian Faculty of Rehabilitation Medicine and the Australasian Faculty of Pain Medicine. So Professor Aggarwal also, in addition to his medical training, completed his PhD at the University of Sydney on motor neuron disease, and he currently oversees a number of research trials at the University of Sydney's Medical School, including trials on trigeminal neuralgia and chronic neuropathic pain. Professor Aggarwal sits on the Medical Advisory Board of the Trigeminal Neuralgia Association, and we're very, very honoured that he fulfills that role. So tonight, Professor Aggarwal will speak on when trigeminal neuralgia pain is too much, presenting to the emergency department for pain management. So Arun, we'll invite you to share your screen and we'll invite the panellists to mute and turn off their video during the presentation.
Thank you very much, Liam, for the introduction. And thank you to the Trigeminal Neuralgia Association for inviting me to speak to you and present this important topic. What I would hopefully like everyone on the discussion today is to try to get some pearls of wisdom out of this and see what they can take to their doctors down the track when they do present to the ED. I've changed my presentation slightly to say present to ED or not, because I'm sure a lot of people in the audience have realized that when they do present to the ED, they don't get much joy when they actually present. And so I'm hoping that you may be able to do a few things at home even before you actually present to the ED, and that may stop you from actually going there. So what we have to be aware of is there isn't too many medications out there which are available for the treatment of trigeminal neuralgia in the medical, which have got medical evidence to support that. So really we have carbamazepine and also oxcarbamazepine as the two main medications that are very effective in the treatment of TM. There is very weak evidence to support the use of medications such as baclofen and lamotrigine, even though there is a big push overseas to be using those as first line and sometimes second line therapy. In Australia, we've gone a little bit further and said that a lot of the medications that are used for neuropathic pain can also be used for trigeminal neuralgia pain. And that's why we've got a whole list of medications here that can be used in TN pain, because it's basically a form of neuropathic pain. So you do have medications such as the antidepressants, which is nortriptyline and amitriptyline. You do have the gabapentinoids, so gabapentin and pregabalin. And then of course you've got carbamazepine as well. And I will focus on a little bit down the track about one of the opioids, which is similar to morphine, but it's called Tepentidol. So it's very important to be aware of, it doesn't matter what anti-epileptic there is available in Australia, it can still be used for neuropathic pain, and also most of the antidepressants as well. And this is a whole list of medications that I keep up my sleeve when people come to see me to say, have you tried this, have you tried that? Because a lot of times people will have tried a lot of different things and they don't respond to the first or second line therapy. But it's important to be aware of that in the treatment of a lot of the neuropathic pain states, the three which are very effective are carbamazepine, Epilum, which really doesn't get a very good run in a lot of the medical literature, and amitriptyline. So Tegretol's always been used first line in trigeminal neuralgia pain. And that's because it's used, it's effective in probably about at least 70 to 80% of people in the first instance. It's not effective in every single person. Now, what I would be saying to people who do have a flare up of their pain is have a look at what dose you're on, because most people may only be on, say, 200 milligrams or 400 milligrams twice a day. But the actual highest dose of carbamazepine that someone can be on is actually 1200 milligrams. So I know there may be some people who are listening to this will say, oh, I'm already on 1200 milligrams. Well, then you don't have much further to go. But if you are on a smaller dose, and then you can add a small amount to your medication regime before you actually present to the ED. So what I'm saying here is that if you're on, say, 400 milligrams twice per day, and you have a flare-up of pain, before you actually present to ED, you could take an extra half a tablet or a full tablet and see whether your pain responds to that. Because as we know, when you go to ED, they'll only give you things like endone and Phenytoin fort, and that's not very effective in these types of pain states. So just have this type of thing up your sleeve to say, oh, okay, I haven't spoken to my doctor about it, but if you feel as though it's been effective for you at the lower doses, then you could try 1 or 2 tablets at the higher dose and see whether that becomes effective. And that's similar to if you're taking trileptal as your maintenance therapy. So a lot of people are on trileptal nowadays because it has less side effects to Tegretol, but it has the same effect on nerve pain. And once again, there may be people who are just on 300 milligrams twice per day or 400 milligrams twice per day, but the full dose of oxcarbamazepine is 1800 milligrams twice per day. And so again, this is something which you could top up with as well before you present to ED. I did talk about sodium valproate, and that's because it is very effective in the treatment of neuropathic pain, but unfortunately, there aren't too many trials on it being done on specifically trigeminal neuralgia pain. And therefore, a lot of clinicians don't use it in trigeminal neuralgia pain because they say there's not much medical evidence for it. But I did do a talk a few years ago where I went through a number of cases and published this in a journal in patients who had neuropathic pain, which was not responsive to other medications. And a couple of these patients did have trigeminal neuralgia pain, and they responded to low dose of sodium valproate. So one of the things that I've been doing in some patients who do present to some of the hospitals that I work in, which in Sydney is mainly Concord Hospital, is because sodium valproate does have an IV form, I've been giving people intravenous sodium valproate or Epilum when they present. So because it has an effect on neuropathic pain, when they present to the ED, rather than giving people morphine or other forms of medications, you can get Epilum in an intravenous form. So it can be given as a slow infusion. The dose is 10 milligrams per kilogram. So generally, if people are around 70 kilograms, you're talking about 700 milligrams of Epilum, sorry. And it's given over a 5-minute period. And it can be very, very effective in that short period of time. And there's only really been one study that was done back in 2002. And I'm thinking now that's going back 20 years ago, where it was given to patients with headache. And it resulted in about 80% of those patients who presented with headache, they improved their pain when they were given IV Epilum. So unfortunately, there hasn't been any trials done on it in patients who have got TN, but there's no reason why it may not be effective in people with TN. Going back to some of the orals, we know that a lot of patients are on Lyrica or pregabalin. And once again, it depends on what dose you're on as to whether you've got room to increase. So if you're taking 150 milligrams twice per day, some of the people in the audience may be on 300 milligrams twice per day. There is a little bit of extra room to go if you're tolerating it. So the maximum dose of Lyrica is actually 600 milligrams morning and night. And so you may want to just top up with an extra dose of Lyrica in those acute exacerbations. And then this is similar to gabapentin. It tends to be more effective than Lyrica, But unfortunately, because Lyrica is on the PBS, most people are on Lyrica rather than pregabalin, or rather than gabapentin. But if you are on gabapentin, then once again, depending on what dose you're on, you've got room to increase that up by taking an extra medication or two during the day. The other intravenous anticonvulsant that I use sometimes when people present to ED in hospital I work at is IV phenytoin. Now, phenytoin is a very, very old anti-epileptic, but once again, there was a trial done, now going back over 20 years ago, where they did a randomized, double-blind, placebo-controlled trial on 20 patients with acute flare-ups of neuropathic pain. And in that 2 hours, there was a reduction in their pain for about 4 days during that time. And usually what this is doing is basically bringing their pain level back to their baseline and allowing them to function with their normal levels of their analgesia. So that's another thing that you could be mentioning to people when you present, rather than giving people opioids. So this is a case that we had that presented a while ago to Concord, a 46-year-old who'd had TN for about 11 years. And she tends to get flare-ups whenever her son's birthday anniversary comes around. And so she had a 5-day history of electric shocks over the right V2 region of her face. And she had failed Tegretol and Lyrica, and generally her pain would respond quite well to gabapentin. And so at that time, IV Epilum was not available, and so we gave her IV phenytoin, and that relieved her pain within 3 hours. There are a couple of other anticonvulsants which are used, which have got IV forms, and that's why I mentioned it in my very first slide, where all the different anticonvulsants that there are. IV Keppra, or the other name is levetiracetam, has got an intravenous form, and once again, there are some patients of mine who respond to Keppra who haven't responded to anything else. And then the newest anticonvulsant on the block is lacosamide, and the other name for that is Vimpat. It's a very, very powerful anti-epileptic drug, and because it has some effects on the sodium voltage-gated calcium channels, it also has some effects on neuropathic pain as well. And I've got about 2 or 3 patients on oral Vimpat because nothing else worked for them for their trigeminal neuralgia pain. And so again, there's no reason why this medication may not be effective in the IV form when people present to the emergency department. So we have been saying that opioids aren't very effective in the treatment of neuropathic pain. And the reason why we say that is because they're no better than the anti-neuropathics. So when there was a trial done between morphine and gabapentin, they were found to be just as effective. And when there was a trial done with nortriptyline and morphine, they were found to be just as effective as well. So a lot of times people will say that they're not effective in neuropathic pain, but another way around that is to say that they're effective, but there are other things which are better to be given because they're just as effective as morphine. But what I would be saying is that there is this new form of opioid, which is called Tepentidol, or the other name is called Palexia. And so this actually, we call this a atypical opioid because it works on 2 different channels. So it works on the mu opioid receptor, but it also works on the descending pathway for noradrenaline reuptake inhibition. And it's this part, which is basically the way that medications such as amitriptyline work. And so this is where it has some effect on neuropathic pain as well. And so this medication, even though it's classed as an opioid, it also has quite good effects on neuropathic pain. And so if someone is going to present to the emergency department and they're about to give you an opioid, I would be suggesting that you suggest to them, rather than giving them endone or Phenytoin Fort, could you please give me Tepentidol, or Palexia is the other name for it, because it'll have this effect on neuropathic pain as well. And the other good thing about Palexia is because it doesn't bind as well to the opioid receptor, it has 18 times less side effects. So less nausea, less vomiting, less diarrhea, and also has less properties for addiction as well. But just because it's not so potent on the opioid receptor doesn't mean that it's not as effective. And the reason for that is because of the noradrenaline reuptake inhibition. That has some effect on pain. Probably everyone in the audience is already on vitamin B12, and I hope that that's the case. There's been a number of studies which have been done that show that even vitamin B12 on its own can be just as effective as some different medications. So there was a trial done in 2009, which indicated that vitamin B12 was as effective as nortriptyline. And so this, because it helps to regenerate myelin, it can help help the nerve signals work better and reduce pain in that way. So to me, I don't mind which type of B12 people are on. I know there are some people who say that, you know, cyanocobalamin is better than mesylcobalamin and things like that. But at the end of the day, any form of B12 will help to improve the myelin sheaths and help to reduce the pain signals. Also, oral B12 is just as effective at getting the intramuscular form. In people who are very refractory to all of the different medications, we do have another option, and that's botulinum toxin. So again, if people are presenting and they've tried everything else, they've failed everything else, they've got lots of sensitive spots on their face, like trigger points, then there is this option of injecting botulinum toxin into those trigger points. And I was fortunate to be able to do this study through the Cromwell Foundation grant for patients with TN. And we published this about 3 or 4 years ago, where we injected 35 units of botulinum toxin into different parts of the face. And all patients had a reduction in their pain by nearly over 75%. And these are just some pictures of where we actually inject. So we'll always inject this just below the zygomatic arch, and then we'll go through areas of pain where they are tender. So injecting 2.5 units of botulinum toxin, injecting into areas where they have increased sensitivity. And from this table, you can probably see that a lot of the patients who received Botox, they had very long durations of pain, sometimes going up to maybe even 10 years. The number of episodes of pain that they were getting, like the sharp shooting pains that they were getting, were up to 40 episodes per day sometimes in some cases. And after two months after they've received Botox, their pain levels reduced down to just about negligible. Because Botox does wear off, a lot of these patients, the pain will start recurring just before the next injections of Botox are due, which is usually around the 3-month period. Another acute treatment is a Spinopalatine ganglion block. So this again, this is because the Spinopalatine ganglion is a very large area of nerves located just back at the back of the nose, and it does get all of his sensory connections from the trigeminal nerve. And so it can sometimes be done in the actual doctor's surgery by putting a tube going up to the nose and infiltrating local anesthetic, but it's actually better done under II control. And this was a case that we had a few years ago. Someone had TN for a number of years, 25 years. She went off and had MVD 5 years after she was diagnosed. And she'd been on all of these different types of analgesics. So the Norseman patch, tramadol at that time, gabapentin and Lyrica. And then she presented with 5 days of very, very severe pain in the V2 region. And so we admitted her to Concord. We gave her the IV Epilum, as I discussed previously, but that didn't help at all. Then she went on to get some Trileptal because she hadn't tried that previously. And unfortunately, that didn't make any difference. And then we gave her intravenous ketamine and lignican infusion. And that relieved her pain within 12 hours. And then because the pain came back after the lignican was ceased and the ketamine was ceased, then we performed this Spinopalatine ganglion block. And that gave a very good pain relief, and that lasted her for over 12 months. So I'll just talk about lignican and ketamine infusions now. We tend to use that in patients who have got a wind-up phenomena where the dorsal root ganglion is overstimulated by all the different neurochemicals and neurotransmitters. It is it has a lot of side effects associated with it when it's given at high doses, especially hallucinations. The oral forms of the NMDA receptor antagonists are not very effective. It's found in cough syrup, which is dextromethorphan. Amantadine is another drug which is actually an NMDA receptor antagonist, and there's a new drug called memantine. But none of them are very effective in the treatment of neuropathic pain because the doses have to go up very, very high. So we did a study at RPA of giving patients who have had lots of different types of neuropathic pain. A few of those did have TN, ketamine infusions, and basically we give them, we run them over a 7-day period with an average daily ketamine dose of 228 milligrams per day. And looking at this, we had a lot of patients who were basically able to reduce their opioid use. And over here's the most significant part. Oops, I'll go back a bit. Where we had 31% of the patients who we put on the ketamine lozenges who could stop their opioid use completely. And so that's the impressive part about this. And as a result of this study, once people have ketamine infusions and get a response, we now put people on ketamine lozenges to keep the response going. Most doctors are more familiar with intravenous lignocaine without the ketamine because it is sodium channel blocker. And once again, a lot of neurologists will give that without giving the ketamine. But we find because lots of patients with TN have got wind up, adding ketamine is more effective than just doing lignocaine on its own. The other thing that you could do at home when you have a flare-up is have some of these Versatis patches on hand. So these are lignocaine patches, and they've got 5% lignocaine in them. And basically, you just apply them to the area where you have the pain. They'll give you a little bit of soothing response in the area where there's pain. And then they also, because there is some absorption of the lignocaine through the skin, you may find that might be enough to reduce your pain levels. And there was a study a few years ago where it found that in a 4-week period, this was in patients with post-herpetic neuralgia, that was more effective than people who were given pregabalin. Okay. The other thing I'll just touch on today is that there are some people who are getting more interested in medicinal cannabis, and there have been a few trials of the use of medicinal cannabis in trigeminal neuralgia. And it's very important to be thinking about this only as a last resort. So I have patients who come to me and they've only tried, say Tegretol and pregabalin, and then they'll say, can I have medicinal cannabis? So it's not something to be taken just when you've only tried 1 or 2 things, but it's towards the end of the spectrum where you've tried lots and lots of things. And the reason for that is because at the moment, the medical evidence for medicinal cannabis is not really there, but the anecdotal evidence is there. So it'll work in some patients, and you won't really know which of those patients it's going to be. And so again, 1 or 2 sprays of medicinal cannabis may be effective in reducing your pain levels during exacerbation as well. So it is something that could be considered. This trial, which was only done 4 years ago, had 42 patients with TN in it, and 81% of them reported an improvement in their condition. It's interesting that a lot of these were on opioids. And most of our patients who in Australia, we don't have patients on opioids. So this was an American study where they put lots of their trigeminal neuralgia patients on opioids. There's lots of different preparations of medicinal cannabis. So I do use it in some of my patients when they have failed most of the conventional things. The most common preparations I find most effective is the combination treatment, which is THC and CBD, because it works on pain, plus it also works on anxiety, because I'm sure people are aware in the audience that there is anxiety associated with the increased pain. The downside of being on medicinal cannabis is that you can't drive, because if you get caught, stopped by a random breath test, then you will test positive for cannabis, and the police don't really know whether you're taking real cannabis or medicinal cannabis. And it doesn't matter if you just show them the bottle, they won't know if you're actually taking the real stuff as well. I'll just mention this very briefly because this is an exciting part of headache management now, and I'm hoping it'll become also into down the track into trigeminal neuralgia management as well. So the CGRP monoclonal antibodies are very, very effective in reducing headaches and migraine because there is so many CGRP receptors on the actual trigeminal nerve itself. And when you think about it like that, there's absolutely no reason why the CGRP monoclonal antibody injections won't improve patients with TN pain. The problem is there's really only been one trial that's been done, mainly because there's only a new treatment where they had 10 patients with TN, and they were given one of the newer CGRP injections, which is that one's called Amavig, and 9 out of the 10 reported an improvement in their pain over the six month period. And so I'm hoping that we will be able to do some additional trials in Australia with this one to try and get this approved for TN as well. So we've got 3 in Australia at the moment that we use for migraine. Amavig, that's not on the PBS. Ajovi is on the PBS, and so is Emgality. And then finally, if all things have not improved with medication, you always have to have that in the back of your mind that patients with trigeminal neuralgia have to be thought of as having a chronic pain syndrome. And so when you have a chronic pain syndrome, then you're going to have influences from the biological side of things. You're going to have some influence from the psychological side of things, and then influences from the social. And so because pain is a perception which is filtered through the brain is going to have some effect on the way that you perceive the pain. And so reducing your stress levels, reducing anxiety levels, making sure your mood is okay, all of those types of things is going to have an influence on your pain. And so it's important for people not to be thinking that the pain's all in their head, but the pain is influenced by what goes on in their head. And so you may get to a certain point where focusing on just a simple treatment, such as a medication, may not be the be all and end all of improving patients of their TN pain. And so we do have multidisciplinary pain clinics where they focus on non-pharmacological therapies and also referring to psychologists with meditation and relaxation. So it is important that there's a holistic approach in patients who have got chronic pain. But I think what I'm trying to get across with today's talk is that there are lots of different options which are available to you. A lot of these options, the doctors, when you present to the A&E department, are not aware of. The reason for that is because pain management is not taught very well in the medical schools of any curriculum. And as a result of that, if you've got the education behind you, you may be able to provide them a little bit more education as to what might be more appropriate for your pain when you go and see a junior doctor who's only been out of medicine for 2 years because you've had pain for 10 years or 15 years and you've seen 10 or 12 different doctors for your pain. And once you've taken all that experience and all that knowledge, then you can impart that to them in the A&E departments. If you've had to present there and say, okay, please don't give me indone now, please give me Tepentidol instead. Okay, you're going to infuse me with something with this, would you have IV Epilum here, or would you have IV Phenytoin? Is there other things that you might be able to give me? Would you mind talking to the neurologist and saying whether he's got any experience in using that? The problem you will find is the neurologist who's on call doesn't have any experience in doing that type of treatment. He may be reluctant to give you that, but depending on where you present, you may be lucky and say, okay, you'll get that type of option rather than getting morphine, which is what patients tend to get when they present to ED. Okay, and then if anyone needs any other advice or any other referrals, then I've got rooms in Rozelle and Hornsby. Very happy to manage people's pain if that's required. Thank you.
Professor Aggarwal, thank you very much for your presentation. I think one of the key points is that there are an incredibly broad number of options for managing people's pain, and that's how I think people should be, encouraged by this. Arun, I'll get you to stop sharing the screen at the moment, and I'll invite our panelists to actually turn on their video and unmute themselves. And if we can just start with the number of questions that have come through, and again, I invite people, if they do have questions, to use the Q&A or the chat function, which is available at the floating menu bar at the bottom of the screen. If you just move your mouse down, and you'll see a floating menu appear, so you can either enter a question through the Q&A or the chat functions. Arun, after that presentation, we might just give you a moment to draw breath. But there's probably a couple of questions in, Lynn. I'm going to direct the first question to you that's come through. Does the Trigeminal Neuralgia Association of Australia publish a consumer guide to pain management?
No, I don't think we do. We search everywhere for good articles and refer to our advisory board. We're always looking for research that is proven and has sort of a good case numbers, and we try and get that out onto our website articles and newsletters. Yeah.
So I think the point that the person that's asking this is that there was a lot of language that's not familiar to people, particularly with the drug names, and recommendations from Professor Aggarwal there about maybe you could suggest such and such a drug regime rather than an opioid, that maybe people were aware of those and had some sort of guide to take to the emergency department. It may be helpful. But that was a very good question, so thank you for that. Eric, maybe the next question to you. I understand that you've had recent experience in attending the emergency department. What drug regime were you offered, and was it effective? And is there anything that you've learned from today's presentation that you would do differently if you presented to the emergency department for your pain management? Now, Eric, I'm sorry that's a very complex question, but we'll just give you a couple of minutes to answer there if you wouldn't mind trying.
Yeah, I mean, I presented on Saturday. I was in excruciating pain, and they really didn't know what to do, and they offered paracetamol, ibuprofen, and endone, and I already knew that none of those work. I suggested I noticed that in Arun's presentation, he suggested tramadol, and I had read tramadol was a possible opioid that you could use, but they didn't want to administer that. I guess from my point of view, what Arun's presented would help if you could pass on some of the information, but I'm not sure how much the doctors, it's whether they really believe that what your problem is trigeminal neuralgia. They don't know your history or anything like that. I have never been to ED for this before, and I had never thought that it was a worthwhile exercise, but I was in so much pain. From my point of view, I probably would have said, well, can you just put me out and try to figure out, some sort of solution, because I was just, so bad. So
Eric, that's probably a good segue into the next question. And I might actually originally, first off, pose the question to Arun, but also ask our remaining consumers their point of view. It's a theme that's coming up regularly in the number of questions that we're getting here is, do you have any advice on the best way to communicate with the ED staff to avoid being seen as drug seeking? Arun, can we pass that on to you first?
Yeah, the one way to not be seen as drug seeking is not to ask for Phenytoin 4 or endone when you present, because I think as soon as the doctors hear you saying, you know, I want some drugs, they'll obviously think you're drug seeking. But I think that I just wonder whether there is something that the people who've got TN, they can be carrying a card around that they're part of the TN association or something like that.
Yeah.
Just so that when you do present to DED, people aren't going around in circles and trying to reinvent the wheel and re-diagnosing people, you know, and thinking that the diagnosis is wrong or anything like that. Because a lot of times the doctors will start from square one again. And then if they know that you've got TN, then they may be a little bit more open to listening to the consumer and saying, oh, well, you actually know what you're talking about. And maybe, you know, I mean, Eric mentioned tramadol, but my actual go-to is Tepentidol,
Right.
because it has less side effects than tramadol and it's a more effective drug. So that's why I mentioned the other name called Palexia, because that's how consumers will know the name of Palexia. So then, you know, you would be saying, okay, well, you know, I've tried, if you say to them, I've tried taking extra Tegretol today, I've tried taking my extra Lyrica, I've done the things that I've been instructed to do by the TN Association. That's not working. You know, now can you try some Tepentidol, because that comes in a IM form as well.
Yeah. So, Arun, one of the suggestions that's coming through is, should a patient or a sufferer have a letter from their doctor when going to ED which suggests some of the medications that might be better than opioids?
Yes, so I've actually got a patient of mine who lives up in the Central Coast who did exactly that. So I think the TN Association put one of my talks of acute management on their website, and she basically copied that and keeps that with her all the time. And so that has IV Epilim, IV Dilant, Phenytoin, Ketamine, Lignican on it. And she basically presents that to them and say, you know, can you give me one of these rather than giving me morphine and endone?
Mm-hmm.
Yeah.
And just to that point, Charlotte, who's asking, a copy of this presentation will also be uploaded to the Trigeminal Neuralgia Association website in an edited form, so that will be available for download for anyone. Peter, I'm just going to ask you a question. You've had some experience of having your pain managed by the emergency department and a subsequent admission. Can you just talk us through your experiences?
Well, I did have a severe pain problem at one stage, but I was admitted straight to the hospital rather than go through the ED on that occasion. And I was on a multitude of medications, including gabapentin, pregabalin, carbamazepine, nortriptyline, and lignocaine. I do have a question though, and that is there any point in taking gabapentin and pregabalin at the same time, which I was on, but I understand that they don't add to each other because they're basically the same source drug. Is that right?
No, actually, Peter, I've got a lot of patients who have failed pregabalin who then respond to gabapentin, even though they're supposedly the same drug. Even up till now, 20 years later, we really don't know which receptor gabapentin works on. We know that Lyrica works on the alpha-2 ligand receptor, but we don't know where gabapentin works. And so even though they're made by the same company and it was meant to be a sister drug of each other, I've always said right from the beginning, gabapentin is a better drug than pregabalin. And, you know, unfortunately, it didn't get put onto the PBS right at the beginning. And so, yeah, I do have patients who respond to one and don't respond to the other, and vice versa.
Right, yeah. I was also at the time, I was being managed by Professor Michael Cousins, and he put me on the nortriptyline as well. But he said, as well as being an antidepressant, it was actually acting as a catalyst to help the others work more effectively. Is that correct?
Yeah, so we call that synergistic effect. And the reason for that is because we're working on a different pain pathway. So Tegretol Tegretol works on the sodium channels. Pregabalin works on the alpha-2 ligand, as I mentioned. And then you've got nortriptyline or amitriptyline working on the noradrenaline reuptake inhibition. So they're all working in different areas. And so sometimes you can have that's why my pain philosophy is giving low doses of 2 or 3 different medications rather than a high dose of just one medication. So I don't tend to have people on huge doses of Tegretol only. I'll have people on 3 different medications at small doses.
Right, that sounds good. I did have a question also about your guide, which we have sent out to TN people to take to the ED department, like you were explaining before. Have you had any feedback to know whether the doctors in the ED actually will take any notice of it, or will they simply ignore it?
It depends on which hospital you go to. So if they've got a pain specialist who's on call at the time, then they'll take heed of it. Because the problem is all the things that we're talking about are off-label. So you could call it experimental if you like. And that's why people who aren't in the know, they will not use it because they're a bit scared of using it.
It sounds like it's worth a try though.
Yeah, but it's definitely worth a try, and you might get lucky. Obviously, if you come to Concord, you'll be fine. But if you go somewhere else, you may have difficulty.
A comment from Ruth here that says, it gives some advice on which hospitals to present to. He says, I was lucky enough to present to an ED because the hospital had a gamma knife suite, so they see a high volume of trigeminal neuralgia patients, and the staff in the ED were familiar with trigeminal neuralgia and didn't even offer me endone.
Good, fantastic.
Excellent.
Yeah.
Obviously, a lot of people don't have the choice, particularly patients that are living in regional and remote areas. But there's quite a number of questions here. And again, Arun, a lot of these are directed to you. So I'll just ask you a couple of these quick questions. And I'm going to paraphrase a couple of them because they refer to much the same subject about ED doctors' knowledge of pain. So how aware are ED doctors aware of the link between anticonvulsants and pain management of trigeminal neuralgia? And are emergency doctors conservative with dosage?
Yeah, so I think what the very important thing is that you don't need to think about your condition as just trigeminal neuralgia. So you have a neuropathic pain syndrome. And so all doctors know what neuropathic pain is. So if you go in there and say, look, I've got neuropathic pain in my face, they will understand that. They don't have to be an expert in trigeminal neuralgia to understand that. And then they will start be thinking, okay, what things do I have that I can treat neuropathic pain with? So what I find really important is that people don't recognize neuropathic pain. Once they do, then they go down the right track. And so if you're already given that information that I have neuropathic pain, rather than giving them a diagnosis, you give them an actual problem to say, I have neuropathic pain involving my face, which is sharp shooting and stabbing. Okay, then you're giving them a bit of extra information which they can work with.
Excellent. I think that's really good advice. Kathy, just, your experience is that your pain was mistaken for dental pain. Is that correct?
Well, I mistook it for dental pain in the very beginning, and I nagged my dentist about it, who claimed that it was not at all dental related. But actually, another dentist I went to did suggest that I had trigeminal neuralgia. Now, that was the first time I'd ever heard of the words. So I remembered that, and gradually over the years, as the pain built up, I thought about it more and more until one morning when I woke up, I couldn't actually move. The pain was so terrible. But somehow my husband got me to the GP, who immediately sent me off to the ED. So when I got triaged, I knew what it was actually. I was pretty sure, even though I didn't have a diagnosis. But the person that saw me gave me endone and some other drug, I forget what, and sent me back home. And I wasn't feeling that I'd got what I needed to get. And as it happened, my cousin from England was staying with me at the time, and she is a GP, and she knows how to talk to medicos. So she immediately phoned the hospital and got put through to the neurologist, who asked me for me to go back. So I went back again the same day and finally saw a neurologist who gave me a tentative diagnosis and fixed me up with an appointment at the neurology clinic at the RPA. He also gave me Tegretol, and that did help, very much so. So I feel that in the end, I did get good service, but if my cousin hadn't been there, I really don't know what would have happened.
Yeah. You know, it certainly speaks to people that obviously don't have somebody, like you say, or, you know, health literacy themselves. But it's, you know, a question that's been raised here is Aaron, what advice would you give to a TN patient who attends ED and are offered Phenytoin for Tridental?
I'll just say, I've had those in the past. It's not been effective. Could I try Tepentidol instead? If you're thinking about that type of thing, but I would hope that before you present to ED, after hearing today, that you've taken your extra dose of Tegretol or your extra dose of Lyrica before you, or extra dose of gabapentin, whatever you're actually on. So whatever you find effective at home for a long period of time, just take an extra tablet of that and see whether that actually reduces your pain.
Okay,
that's going to be more effective than any other thing that someone in ED is going to give you.
And then in some of the topical treatments like Vaporate, one of the questions is, what's the shelf life of topical treatments? You know, and do people have those at home ready to use for occasional outbreaks of pain?
Yeah, so they're all in seal packets, and when you buy, they've all got expiry dates on them, obviously. But I think 2 or 3 years would be the expiry dates. And so, you just break the seal and then use it. It comes in a pack of 5. So
it's very feasible to have those at hand for the
occasion. Yeah, and then stick it on your face and see how you go. Yeah.
One of the questions comes through, and again along this theme of emergency doctors' knowledge of neuropathic pain, is what do we need to do to educate emergency doctors regarding trigeminal neuralgia? Because you've made the comment that they're not trained well in medical school.
Again, sharp, stabbing, shooting, burning, electric shock, just use those words. So once they hear those words, then something will trigger in the back of their mind. Okay, that's nerve pain.
So just to paraphrase that, is that if sufferers of trigeminal neuralgia can actually describe the pain in those words, more likely to get appropriate pain.
If they just say, "Oh, I've got really bad pain in my face. Oh, I can't handle it. Oh, it's so bad," that's not going to make any difference. Now, Peter, I'm going to direct the next question to you, and you can defer it to other people if you think they're more appropriate to answer it. But if the patient is having increased suicidal ideation, should that be a trigger to go to the ED?
Sorry, who are you aiming that at?
Peter, I just was sharing these questions around, just your thoughts there.
Oh my goodness.
And like I say,
I think that's way out of what I can give an answer to.
That's fair enough, Peter. I didn't mean to put you on the spot. Maybe would anyone else like to have a go at that?
Well, I would say that maybe the first option would be to call Beyond Blue as the first option. Certainly to alert a family member that they can perhaps get some counselling or some medical help for you, and to support your mental health in that way.
Yeah. Arun, can we hear your opinion on that as well?
Yeah, I think that obviously that's a cry for help, and they're not managing their pain very well. Some neurologists do allow patients to email them. I do. So I do have patients who will email me, with my pain's got really bad. What do I do? And then I'll respond to the email. So I don't know if you've got that type of access to your neurologist or your pain specialist, that's always a good option. You can always, after you've been seeing them, 2 or 3 times, you could say, well, if I do get into trouble, can I contact you in some way? Most of them don't want to be called on the phone, but by email, they may be willing to do that. And so I'll usually respond to my emails around 10 o'clock, 11 o'clock at night, but at least I get to the emails at some stage or the other.
Arun Wood being a good key man answering emails at night. So, and again, one of the questions that comes through, and it's related to Arun, your some of your concluding remarks about the use of multidisciplinary pain clinics, where it isn't just a pain specialist that's managing pain, that you've got the multidisciplinary, both with psychologists and various other disciplines. So people ask, how does a person actually access a multidisciplinary pain clinic? Is that through their neurologist or other means of referral?
So it can be in a few different ways. You can get a referral just from a GP. You can also get referral from your neurologist or your pain specialist. You may not be working in one of the pain clinics. Like in Sydney, there's only about 4 in Sydney that have got multidisciplinary services. So North Shore, Prince Alfred, Westmead has a kind of service. Liverpool has also a pseudo service as well. The Hunter has got a multidisciplinary one. So that, I mean, it's hard to get in sometimes, but you have to be, when you're referred to one, you also need to be open to their suggestions as well. So if you're completely medicalized and feel as though that absolutely, talking about my pain, thinking about my pain, meditation and relaxation is going to do absolutely nothing for my pain whatsoever, then it's a complete waste of everyone's time going there, because you're just way too entrenched in your pain syndrome.
Can I add something there? A few years ago, I moved from Sydney and moved to the country, and I decided to see if there was a pain clinic in the Northern Rivers region, and there was at Lismore. I contacted them and just to talk to them, and they did talk to me, and I asked them if anyone there actually had experience with TN and were knowledgeable in that area. And one of the people was. So I knew that if I had a problem in future, that I could actually contact them and they may be able to do something. So I sort of planned that ahead.
And Peter,
in the end, I didn't need it. When I finally did have a problem, I flew straight to Sydney to the RPA.
Yeah, okay, so Peter, you've answered the question I was going to ask, is what was your experience with the multidisciplinary pain clinic?
And again, Liam, I think that Peter also is saying, do you have experience with TN? When you get to a certain point, you don't have to have experience with TN. You have to have experience with chronic pain and nerve pain. So what I'm trying to get across to a lot of people who are on the, who's on this webinar is, I know you all think that, TN is a very special disease, and sure, yes, it is. But when you present to a doctor, the doctor is really looking at you as a patient who's got nerve pain. And, a lot of people may have been diagnosed with glossopharyngeal neuralgia, trigeminal neuralgia, occipital neuralgia, whatever, but their pain is exactly the same. It's still sharp, it's still shooting, it's still stabbing. And so, any doctor in a pain clinic has got experience with neuropathic pain or nerve pain. So don't think to yourself that, oh, I can only go to a doctor who knows about TN.
Thank you, Arun. Good advice. Eric, probably just in regard to time, just your last question. I'll throw the floor open to you to ask your question that you put there.
I was just asking what's Arun's opinion and maybe yours on surgery versus pain management medication.
So from my point of view,
I imagine it depends on the case, but
no, I think surgery always has a role in TN. If you've got microvascular compression of your trigeminal nerve, if you do not have any compression, then I don't feel surgery has got a role.
Right.
So there are going to be people who will operate on you, but after surgery, you will still have pain. Right. And so you won't get a good result. And so I would probably stay away from those types of people who would operate on you. Of course, microvascular decompression does very, very well when it's done by the right people as well. So you need to make sure you go to someone who's done a lot of them. And the results are amazing for, can be up to 10 years. And then after that, patients can come off their medications because it's done such a great job. So I wouldn't go to MVD right from day one, because there are going to be lots of people who get benefit just from medication. And so I generally refer people to surgery once they aren't being controlled with medication, or if they're getting side effects to medication. Then I will send them to surgery in addition to them having compression of their trigeminal nerve.
Yes,
It can depend a lot on the cause of the TN. In my case, it was actually a tumour growing in Meckel's cave, but again, it was compression though of the ganglia.
Right. If there's no compression, there's no point going to surgery.
Yeah.
The difficulty is knowing, you know, I don't know a neurosurgeon from another neurosurgeon from a bar of soap, you know, so to say that, you know, like I've had an MVD done and it did work for a couple of years, but now it's not working. And, you know, they thought that there is compression there, but, you know, I don't know. So it's difficult, you know, when I spoke to the neurosurgeon, he seemed knowledgeable of it, and he had said that he had done other MVDs and stuff. So, yeah. That's why I asked, because I'm looking to have the MVD done again, because if it does work, you know, I'm on Epilim and I don't like Epilim for its side effects, but nothing else has worked for me. So,
I mean, that's why we've got 2 or 3 on our medical advisory board.
Right.
So that's what we'd be suggesting, just maybe source them out.
Yeah.
Yes.
So just in the interest of time, I'm just going to try and paraphrase probably what I consider the key learnings that we've got from today, particularly from a consumer perspective. That is, have a strategy for managing your own pain at home before you present to the emergency department, and, you know, try increasing your dose, have topical treatments at hand to try those. If you do need to present to the emergency department, be able to describe your pain, not specifically as trigeminal neuralgia, but as neuropathic pain, and be able to describe it as shooting, stabbing. That's something that'll give the emergency department doctors an indication that it is neuropathic pain. And also to have some idea that you know, potentially the use of opioids, or ask for a different regime apart from the opioid. Would anyone like to add anything to what I've tried to summarise the discussion tonight?
Yes, I think the idea of having some sort of TN ID is great for presenting at ED.
Yeah.
Yeah, I was just thinking the same.
Gonna concoct something.
Yeah. And maybe Lynn, you can
maybe the TNAA could make some little cards.
Well, I was thinking the same thing. We can certainly provide a plastic credit card wallet size card with some really relevant information and a reminder to say neuropathic pain, and explain the way the pain is actually affecting you. So I think that's a great idea.
Excellent.
Yeah, we can put some little bullet points on the back of the card and just say these are the things that we'd be suggesting to presented.
I think that's all sound like great suggestions. So Lynn, I'm going to hand over to you in just a moment, but first of all, I'd like to thank all of our panelists for their input. I'd also like to thank the audience. I do apologise to the people that have raised a question that we haven't been able to get, but if you can send an email to the Trigeminal Neuralgia Association, we will try and direct a response to your question there. But thank you to everyone that's attended for their participation. And most of all, I'd like to thank Arun Aggarwal for his expertise and his generosity in offering his time to present tonight. So over to you, Lynn, to wrap up this session.
Thank you very much, Liam. Well, my sincere thanks to both Arun and Liam for the chairing and presenting, and also our panelists. So I realise, Eric, you've been in a lot of pain, so it's been quite hard for you to sit there for an hour. So I appreciate that time. Please, anyone who has TN who's watching this, please get in touch with us. You don't necessarily need to be a member. We've got support groups all around the country. We're on the other end of a phone or an email, or contact us through our website. and we will try and direct you and provide some advocacy for you. Thank you very much.
Excellent. And if I can just add that we'll advertise our next webinar. We still plan on having 2 more webinars later on in this year, and they'll be advertised through the usual channels of social media, the Trigeminal Neuralgia Association website. But again, thank you to everyone for their participation and their input into tonight's webinar.
Thank you.
Thank you.
Thank you.